Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your college of entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is cytomegalovirus. Cytomegalovirus has a global distribution and most acquire primary disease as a child. Seroprevalence in the UK is 65%, which increases in at-risk populations, for example, MSM. Higher disease burden is seen in those with immunocompromisation. Here we can see a histology slide, which shows the classic owl eye inclusion seen with CMV infection. So particularly if you see this in part 2, for example, this can really only mean that it's an infection with cytomegalovirus. Primary CMV is often silent. It may cause glandular fever type illness and hepatitis. Severe infection may be secondary to seropositive organs being transplanted into a seronegative donor, which may lead to CMV reactivation. Congenital infection may complicate primary CMV during pregnancy, resulting in fetal malformation. CMV is diagnosed serologically through IgM. Recurrence is diagnosed through clinical suspicion and detection of the virus through PCR or detection of antigen in the blood. It may also be diagnosed through tissue if this is accessible. Fetal infection is associated with excretion of virus in the urine. Treatment of CMV is with IV ganciclovir or foscarnet in the immunocompromised. So let's try a question. 42-year-old HIV-positive man with a CD4 count of 30 cells per microliter presents with a 2-week history of fever, fatigue, shortness of breath and dry cough. A chest X-ray shows diffuse interstitial infiltrates. Blood tests reveal a positive CMV PCR. Which of the following is the most likely diagnosis? So our options are pneumocystis jirovecii pneumonia or PCP, bacterial pneumonia, cytomegalovirus pneumonia, tuberculosis, or aspergillosis. So just given the demographic and also the fact that we have a positive CMV PCR on a background of specific symptoms leads us to the diagnosis of cytomegalovirus pneumonia. If you'd like to hear more about any of the other types of infections that are here, you can check out our video on tuberculosis, which was earlier in this series, or aspergillosis, which again was a couple of videos previous to this one. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.